Intuition is a remarkable thing. Even in the moments when physical dangers do not feel either clear or present, sometimes we just know.
I just had this, I can't even really articulate it in words. All I can tell you is if you've been through it, you know what I'm talking about. I just had this horrible sense of foreboding that my life was in danger.
Every 6 minutes, somebody in America dies of a blood clot.
We're here to change that statistic. Welcome to Taking a Breath, a Stop the Clot podcast.
A podcast dedicated to bringing awareness of the dangers of blood clots from the clotting disorders community to the world.
With the help of many notable blood clot survivors, we are here to give you the knowledge and the skills that you need to prevent this silent killer.
My name is Leslie Lake. I am the president of the National Blood Clot Alliance, and I am a blood clot survivor.
And my name is Todd Robertson. I am the patient engagement liaison for the National Blood Clot Alliance, and I am a 7-time blood clot survivor.
And we're here to stop the clot. It goes without saying that life can be exceptionally difficult. From the financial to the systemic to the medical, expect the unexpected should be the universal slogan for the lived human experience. The one unifying element that allows coalescence and growth as individuals, from the mundane to the traumatic, is understanding. Our guest today is someone whose resonant understanding of the human experience and propensity for empathy for focused care and connection with his patients is second to none. Please join me in welcoming oncologist, hematologist, father and friend, the forever profound Dr. Mark Lewis.
Hello, my name is Dr. Mark Lewis. I am a medical oncologist, and specifically, I'm the director of gastrointestinal oncology at Intermountain Health, which is a multi-state healthcare system based in Salt Lake City, Utah, where I live. And though I've led with my professional title, I think the most important thing you should know about me is I'm also a patient. So I'm a patient/physician, and I'm always a patient before I'm a doctor. And then most importantly for today's discussion, I am a blood clot survivor. So one of the things that I've learned is there's a huge difference between the teaching I received in medical school and what I'll call my embodied experience as a patient. So when I was in medical school, as is the case with many students, I was taught that one of the presenting symptoms of a pulmonary embolism, a PE, is an impending sense of doom. But frankly, I never knew what that meant until I felt it myself. And the analogy that I would draw now is it's the difference between a pilot and a bird. So a pilot understands all of the forces that are involved in flight. They understand lift and thrust and drag. But the bird just feels. And I often wonder what patients actually have to teach their doctors about the visceral experience of blood clots in particular. Because again, impending sense of doom, frankly, meant nothing to me. It was just a phrase I memorized until I awoke one morning and I felt it myself. So there's a little bit of context here. I'd had a pretty complicated pancreas surgery to remove cancer from the head of my pancreas in 2017. It was a life-saving surgery, but also a life-altering one. In some ways, I've never been the same since. One of the long-term complications of that surgery is that from time to time, my stomach can just stop working. So I can develop this condition called gastroparesis, literally meaning stomach paralysis. And the reason that's relevant here is when my gastroparesis is at its most severe, I can't eat at all. Everything I put into my stomach just doesn't move. And, most upsettingly, it can come back up as this kind of disgusting bilious vomit. And I'm a GI doctor, so sorry if this is a little bit nauseating. In late 2019, I had this stretch, essentially from around Thanksgiving onward, where I couldn't eat. Actually, I have a vivid memory that year of being at the Thanksgiving table, and it almost felt like sour grapes because everyone else was digging into turkey and stuffing and cranberry sauce, and I couldn't have anything. So I got to the point where I really was becoming malnourished and cachectic, losing a lot of weight. and my doctor said to me, Mark, you're 2 years out from surgery, but we need to treat this as a post-operative complication. So my surgeon took great responsibility for an operation he performed over 2 years previous, and he set me up with this form of intravenous nutrition. There's many acronyms in medicine. This one's called TPN, Total Parenteral Nutrition. The idea basically is that you're fed intravenously in a manner that gives your body all the nutrients it needs, even if it doesn't entirely take away your hunger. So this was sort of a last resort, and it did, in fact, sustain me. So I was on TPN for the entire month of December in 2019. The way TPN works is every week you get your labs checked, and then there's this custom recipe that's made just for you. And it comes in these big white bags, which is kind of fatty fluid that you put in the fridge, and it gets hooked up to your IV. And my kids, very touchingly, would call it my arm milkshake. So we get this big bag out of the fridge, and we start infusing this stuff, and it takes a long time to go in. It doesn't feel like food, but on some level, and some almost intellectual level, you know that you're getting nourishment. It was such a weird month because, I've got my head and then I've got my body. So as a doctor, like, I can intellectualize the fact that this drip is giving me everything I need. But this is let's be honest, completely unnatural way of surviving and sustaining oneself. And so I guess what I learned is, again, sort of the teaching that comes with experience, the ultimate teacher. It doesn't actually take away hunger, at least not completely, because nothing is actually going into your gut. So your gut is like torn because, again, on some very primitive level, the stomach needs to be filled, and yet it's not. I had this kind of cognitive dissonance that entire month where I knew I was getting the nourishment I needed, but I couldn't sense it in the way that a traditional appetite would be stated. So that was December of 2019, and January of 2020 was, of course, a momentous month or start of a year for all of us. Very early that month, again, I've got this big IV in my arm. This was designed to be in my body for longer. So it was a really special, larger diameter catheter called a PICC line, peripherally inserted central catheter. So imagine a thicker IV, one that starts in the arm, but actually ends just above the heart. And while that sounds scary, the idea is that right above the heart is one of your largest blood vessels. So now what you're doing is you're actually putting this quite viscous and potentially quite irritating substance concoction, the TPN, into a larger vessel. And I tell patients all the time, as a GI doctor, the gut is just plumbing. And on some level, our blood vessels are plumbing too. So bigger pipe, less resistance, easier delivery of a fluid. So I woke this one morning in January. It was probably about, 3 a.m. So it woke me from sleep. And I had chest pain, and I had, drumroll, the impending sense of doom. I just had this, and I can't even really articulate it in words. All I can tell you is if you've been through it, you know what I'm talking about. I just had this horrible sense of foreboding that my life was in danger. Having said that, yes, I'm a doctor, but I'm also a patient, and I am allowed to make decisions that are not maybe the ones I would make if I was my own physician. So I laid there for about 4 hours. My wife was sleeping next to me, and I suppose I like to let myself off the hook and saying I was trying to be a considerate husband and not disturb her. But she's a doctor too, so when she woke up around 7 a.m, and I told her I'd had 4 hours of chest pain and an impending sense of doom, she said, and I'm not going to sugarcoat, she said, "You idiot, why didn't you wake me up? And also, you're a doctor and you should know better." So as you can imagine, we went to the emergency room, and a few things get you to the head of the line faster than saying you have chest pain. So I was really impressed. I came to my own ER, my own hospital, and I got to see how things work from the patient side, which was very illuminating for me. So again, triage worked perfectly. Chest pain, understandably, got to rule out some life-threatening causes. So really quick EKG. Thankfully, there was no evidence of strain on my heart. However, a rapidly obtained CT scan showed that I had a pretty substantial pulmonary embolism. And so what had happened here, just to really spell it out, this catheter through which I've been getting what I might call liquid food had, for want of a better phrase, irritated the inside of this vein. It caused a clot, a thrombus to form, And I don't know how long the clot had been there. It could have been there for weeks, actually. And then finally it broke off, and the first place it's going to lodge, because of where the line ends, is in the lungs. A lot of patients, when they experience a pulmonary embolism, their clot comes from the lower extremities, and that's far more common. In fact, I'd say it's something like 40 or 50 times more common than an upper extremity thrombus. But that's what I had because of the location of this IV line. Regardless, once it ends up in your lung, it's a PE, no matter where it originated from. And man, it hurt. And again, as a doctor, I got to see my ER colleagues sort of leap into action. They wasted no time. They diagnosed it very swiftly. And they started me immediately on blood thinners. And here I have to comment, I have to put my white coat back on. When I was a resident and going through training, which was in the early 2000s, it was routinely the case that when you had a new diagnosis of a patient with a pulmonary embolism, you would put them in the hospital for days. You would run this IV drip heparin, and heparin is notoriously kind of difficult to get the levels right. So you had to constantly be checking the thinness of the blood and make sure the anticoagulation was appropriate. So I was actually kind of blown away that modern medicine has advanced, again, to the point where now as a patient, my treatment was completely oral. They put me immediately on an oral anticoagulant, and they said, okay, you can go home. You just need to fill this at the pharmacy. So literally in a matter of hours, I had the diagnosis I needed. I did not have to be admitted to the hospital, and I was started an appropriate medicine that I could take at home. And it was really remarkable to me to learn just how quickly the anticoagulant made me feel better. And I'm lucky because my clot was provoked. So we know from the IV line, that was the cause, that was the source. So I have not had to remain on blood thinners indefinitely. I was on them for 3 months and then I stopped. For what it's worth, I still have a small supply on hand. For instance, I just took an international trip where I flew to South Korea, and sometimes I keep some blood thinners with me just in case I think I've got a clot coming back. But honestly, this was my real world education in something I learned about more than 2 decades ago as a medical student. And I'll be a broken record. There's nothing quite like the experience of going through a medical condition. One might even say a medical emergency. It's completely different than reading about it in a book.
When we talk about survival and resilience in the face of seemingly insurmountable odds, a key ingredient, oftentimes, to surviving the unsurvivable is hope. The ability to see the beauty and joy of life during its bleakest moments is a powerful asset and a beacon to the resiliency of the human spirit. Here to discuss the power of hope, again, is Dr. Mark Lewis.
You know, when I see people go through the true rigors of chemo, the low points, I know that they are almost certainly going to recover from each cycle. I actually will often quote to them, hopefully not sounding too inauthentic, what my dad said. So when my dad was going through a really awful, almost kind of medieval chemotherapy, poorly controlled nausea, terrible suppression of his immune system, he actually wrote, this was in the early 90s, he said, anything is tolerable if you can just see the end point. And I think a lot of hope, so it doesn't come across as false hope, which we don't want to overpromise and deliver. A lot of hope is based on what we think is going to happen. So I can intellectualize, I can tell patients, listen, yes, with each chemo cycle, you're going to enter what I call the nadir or the trough. And I say, I can also predict that you're going to come out of it. And so when you're in the valley, you just have to remember that an ascent is almost guaranteed to happen. But patience is really hard. Like in the moments when we're feeling pain or we're nauseous, it's almost like time elongates, it plays tricks on us, it elasticizes, it feels like it's taking forever. And then the good times, of course, are so fleeting, right? Like time flies when you're having fun. I really try in the sort of cognitive part of my brain to provide my patients with, medical reasoning that I do expect them to recover and get better. And I can do that both on a cycle-to-cycle basis. I can even zoom out and sort of see that on a longer time frame. But the other thing is, I would argue that hope is fluid. So now we need to talk about, well, what exactly are we hoping for? Everyone, when they come to me, well, almost everyone will ask at one point or another if they can be cured. And just to let you peek behind the curtain, what's supposed to happen in your very first visit with an oncologist. So you have a cancer diagnosis, you go to see a specialist, we're supposed to tell you, this is part of our quality metrics, we're supposed to tell you in that very first conversation, are we intending to cure you, or are we offering what we call palliative treatment? Now that in and of itself sometimes gets mistaken for hospice, and they're not synonymous. Palliative means we can control your disease for some length of time, but we don't expect the cancer to ever go away. And so what I'm getting at is this. A lot of people come in understandably expecting a cure, and I can tell them with some pretty brutal honesty at their first visit that I don't think I'll ever be able to cure them. But then we have to quickly pivot into thinking of this more as a chronic illness. In the same paradigm as we might think about, diabetes or hypertension, conditions that people traditionally don't expect to kind of come out of. And that's really difficult because there's so much in the public consciousness about cures for cancer. But to be very honest with you, in my practice, and there's a lot of selection bias here, I would argue that probably over 2/3 of my patients are never going to be cured. And that's true from the moment they walk in my door. So I think it's, what are we hoping for? So one of the things that my patients start legitimately hoping for, and this is going to sound weird at first, is they hope to die with cancer, not of cancer. And I've seen that happen. Like I've seen people, like my oldest patient is 106. I've seen people live with cancer to very, very robust lifespans. And then the final thing I'll say is, so I don't sound too blinded by optimism, is yes, patients do die. So just this week, in fact, I lost a really dear younger patient. During the last weeks and days of her life, she was extremely focused on quality and comfort. And so what I often tell folks is, listen, it's totally fine for hope to change and adapt. Everyone almost without fail initially hopes for cure. Then we hope for control. And really, I think we always are hoping for comfort. And those things don't have to be mutually exclusive. Sometimes control and comfort go together. But to me, there's nothing wrong with admitting when we are out of therapeutic options and we focus exclusively on someone's comfort. Again, that's not really a failure, or it's certainly not a failure on the patient's part. And frankly, it's the reason we're constantly doing research, is we want to have more treatments to offer, but sometimes we're just out of options. So I think it's being willing to have our hope change with our circumstances is probably the most important adaptation that we can make.
Mark, first of all, I feel like we all know you, like you're one of us. And so there won't be a Dr. Lewis. It'll be Mark in conversation, which I know you're great about. But I mean, you've brought just such an incredibly unique experience. You are a clinician, but you're also a patient. And there aren't that many of you. And you look at this problem through two lenses, and so just love to get your feedback as a patient, as a clinician. Like, how has it changed the way you think about VTE, with the way you communicate with patients, and sitting in the patient chair? What would you say to both patients and clinicians?
Yes. So thank you so much, Leslie. And yes, I certainly am happy to be called Mark, because I am a patient first and always. I'm a physician most of the time. I think I have a lot more empathy now for what we might call, and I hate this term, so forgive me, we might call the difficult patient. I think that's a grossly outdated and inappropriate term. And I think, unfortunately, it sort of came to mischaracterize patients who were self-advocating. And more than once in my career, but more importantly, more than once in my experience as a patient, I've really had to stand up for myself. And I realize in doing that, I have a tremendous advantage, which is I can at least play the card of professional courtesy. My peers might not necessarily like it, but when I sort of invoke, hey, listen, I've got a medical license too, I just need your help here. That gives me a slight advantage, I think, over people who are completely outside healthcare. So both to get my initial cancer diagnosis and also, to be very honest with you, even a little bit when I was experiencing thromboembolism, I really had to sort of emphasize my credentials. And I just don't think that's fair. Like it shouldn't be the case that someone like me gets special treatment over someone who doesn't have a doctorate. So all of that's to say, I think we need to reframe this. I think patients who look out for themselves and report symptoms or side effects earlier, I think objectively do better. So we can certainly talk about how that specifically relates to clot and clot risk. But I'll tell you, there was a really fascinating study. I'm going to put on my oncologist hat for a second. Came out about 7 years ago. And this happened at our biggest cancer conference of the year. So it's kind of like the Super Bowl for oncology. And so they pick typically like 4 or 5 studies that they think have the greatest impact. And one of the studies they presented that year was not looking at a drug or a treatment at all. It was looking at the survival advantage, which was measurable, of patients reporting their symptoms and side effects between visits. So the way I look at this as a doctor is I see my patients in like this punctuated equilibrium. So for instance, it's pretty common in terms of rhythm that I would see someone every 2 weeks or every 3 weeks. But what this study showed is if you give patients the tools to report problems that are arising between those appointments, and again, this is kind of common sense if you just think about it, outcomes are a lot better. You catch acute problems a lot sooner. And I think this is a really important shift in thinking. My grandmother, who I dearly loved, once had a heart attack on a Sunday and didn't tell anybody about the chest pain until the Monday because, quote, you didn't bother the doctor. And, if she was still here with us, as a doctor, I'd very gently say to her, listen, this is our job, is to be here and respond to you, especially when you have a need that frankly can't wait. So to bring it all the way back to my patients and messaging around clots, I really try to educate almost all of my patients, actually, because cancer is such a risk factor for hypercoagulability. I try to educate them on the science of clotting, whether that's a DVT in an extremity or, more acutely or severely, the sensations that go along with it with a PE. And on the latter, I have to reiterate that it's one thing for a physician to learn about PE, to know the right tests, both blood work and scans to pick it up. It's completely another, though, I found, to experience it yourself. And so I think it's made me attuned also to the fact that not everybody comes with sort of a stamped red flag that says, okay, I'm having, pleuritic chest pain arising in the setting of, thrombophilia. It's not normally always that clear cut. So I guess I have a pretty low threshold now to advise my patients to report whatever they think is wrong or new, and also to investigate to rule out clotting, because as we all know, blood clots are a really serious threat. They really are one of the greatest comorbidities, concurrent problems that affect my patients and frankly, lead to mortality sometimes. Oncologists are asked pretty commonly to prognosticate. So people will ask me, doc, how long do I have to live? And, usually my answer is approximated as, say, months or years. But a DVT, and specifically a PE, is a really serious short-term threat. Yeah, and I will say that in cases where I've seen my patients have their lives unexpectedly cut short, and I'm sorry to be morbid here for a minute, oftentimes when an autopsy is performed, we find out that there was a clot that was responsible. So as much as I try to see the future and I try to see years ahead for my patients, on a day-to-day basis, we have to be very vigilant for clotting. And so my final word there is, there really is no such thing as the difficult patient. Especially these days, we have more tools than ever for what I would call asynchronous communication. So it used to be the case, really your only chance to communicate with your doc was probably at a visit, and that visit may not happen very often, and it might be very short. So time would be, of the essence. These days, we almost all use electronic medical records. And I really encourage my patients to drop me a note in there. It's kind of like secure email if they're concerned about anything. And it's my responsibility and my team's responsibility to try to turn those messages around in no longer than 24 hours. And again, what this results in, just to give a more concrete example, is let's say someone has a pain in one of their calves, right? This actually happened very recently. And yeah, sure, it could be, it could be a muscle strain, but maybe it's something more serious. So it allows us to get to work on, investigations like ultrasound sooner rather than later. And I even went through the same process myself, Leslie. So about a month or so ago, I've been doing a lot of yard work, and I kind of slipped awkwardly, and I thought maybe I had, sprained my calf. But as the week went on, it was getting more and more swollen and asymmetric. And I have a history of PE, as you know, so I was like, I wonder if I need to get this investigated. So I guess my point is, to practice what I preach, I did exactly that. And I contacted my doctor and was like, hey, listen, I think I need an ultrasound. We got it done. It was reassuringly negative. But it just showed me again that I have great privilege. I think I have a pretty easy time calling a colleague and asking for that. And I don't want patients to feel like they're in opposition to their doctors. Our job is to take care of them. And again, it's not customer service per se, but it really needs to be a relationship where we trust one another. And that involves, on the doctor's side of the table, listening to the patients and really taking their concerns seriously.
Thank you for that. And, we have so many patients, as you know, that come to us. And, there's certain groups that I would say are more susceptible to what I'll refer to as gaslighting, which is an unfortunate, thing for a patient to experience. And so, hearing you say, hey, I've experienced issues and I had to use my credentials, I think is really empowering, because we want those folks to say, no, I want this, or I think this may be it, and to be taken seriously. So for you to acknowledge it, as frankly, as a internationally acclaimed physician, really gives merit to what we're trying to do here. Mark, we want to thank you for joining us here today. It's been an amazing discussion. And if we could clone you, the patient community would be so much better off. But we're making advances in medicine, but I don't think we've advanced that far yet.
That's very kind of you. I'll point out, as my genetic blueprint is a little bit flawed. I've definitely got mutations, but that's very, very kind of you to say. And I'll just say that, your cause definitely overlaps with mine. Like, there's this huge Venn diagram of sort of mutual interest between your work and mine as an oncologist. So I'm really grateful for your advocacy as well.
And we're grateful for yours, and may we continue to work together and save lives. So thank you again for joining us today. We want to thank Mark for sharing his lived experience and his joyous insight into what it means to be human. We would also like to thank you for joining us here today on another episode of Taking a Breath. For more information on risks, prevention, and community, please visit stoptheclot.org.
We know the patient because we are the patient. Together with listeners like you, we can collectively stop the clot.
Another Everything Podcast production. Visit everythingpodcast.com, a division of Pattison Media. Subscribe wherever you get your podcast.